Hello everybody, this is Carlos from Army of Nurses and welcome to another video. Today's quick guide video for nursing students will be a review of the anatomy and physiology of the respiratory system. So respiratory system consists of the breathing airways and the lungs for air exchange. It is worthy to point out that obviously the lungs are located inside the thoracic cavity. The right lung has 3 lobes, as you can see over here, and the left lung has 2 lobes, right? Also the oral airway, so we have the nasopharynx, up here, the oropharynx, epiglottis, which is the flap that will close the lungs or close the esophagus so the food doesn't go into the lungs. The larynx, this is your voice box. Trachea, which leads the air down to the lungs, to the pulmonary bronchus, and then into the lungs bilaterally. Your diaphragm is down here. It's one of your breathing muscles. And once we take a closer look into the layers of the lung, you can see that the lung has a few layers there. So there is the parietal pleura, right? This is the one that is close to the intercostal muscles, as you can see over here. There is a pleural space which is filled with pleural fluid to allow the lungs to to slide against each other when you inhale and exhale, so that it decreases friction. And the visceral pleura is the actual layer that is close to the lung tissue itself. So some of the functions of the respiratory system include air transport and gas exchange. It's also a first line of defense against microbes. It's useful to produce sound. And the respiratory system is very important in the management of pH, right? So it's air transport plus gas exchange. It's a first line, of defense against microbes. It also works for sound production and plays a crucial role in acid-base balances. So next we're going to talk about the airflow in and out of the lungs. The airflow in and out of the lungs, it has to do with pressure gradients. So during inspiration, that's when air flows in, and will be active. Right? Inspiration is active, and expiration is passive because the air leaves the lungs because of the passive recoil of the lung tissue, right? So passive. That was. So the airflow in and out of the lungs. So air moves from an area of high pressure to low pressure. So we're gonna put high pressure to low pressure, right? We cannot control pressure directly, so we can control volume instead. So we cannot control pressure directly, but we can control volume. So what does this mean? This means that when we breathe in, the respiratory muscles, they can affect volume. If you take a look at the inspiration here, when the diaphragm during inspiration expands and the intercostal muscles expand, what we're doing inside the lungs here, we're increasing the volume. And because we're increasing the volume, the pressure inside the lungs becomes less, right? And when the atmosphere pressure becomes more positive than the pressure inside the lungs, then the air, it's going to move into the lungs. And the opposite happens during expiration. During expiration, when we relax, when the respiratory muscles relax, you see that the volume becomes smaller, right? The volumes become smaller inside the lungs. Because the volumes are smaller, that means that the pressure inside the lungs will be a little bit higher. And because the pressure is higher inside the lung compared to the atmosphere, air will flow out. This is one of the laws of volumes and pressure called Boyle's law, that dictates that when volume is high, pressure is low, and when pressure is high, volume is low, right? It's the opposite of each other. So when volume increases, pressure decreases, and when volume decreases, pressure increases. Okay? Now next, we're going to talk about some type of the types of respiratory airways, and there are two types of respiratory airways. I'm going to divide them in the middle here. So one type of respiratory airways are the conducting airways. Conducting airways. I wish I could talk as fast as I wish I could write as fast as I can talk, but just cope with me. And the second type of respiratory air are the respiratory airways. Respiratory airways. So conducting airways and respiratory airways. What are the differences? So conducting airways, they warm, humidify, and filter the air. They do not participate in gas exchange because they do have this anatomical dead space, right? There's air that is trapped inside your airways, right? The trachea and the bronchi. And there's about 150 cc's of air in there that do not participate in gas exchange. So they warm, humidify, plus filter the air. So no gas exchange. And it's about 150 milliliters of air, right? So it's called a dead space. Now for respiratory airways, these are composed of the respiratory bronchioles, and the alveoli. And like you have guessed, the function of the respiratory airways is for gas exchange, right? So gas exchange, which is a very, very important function of the respiratory system. Now we're going to talk about the alveoli. So the alveoli is the smallest unit in the lung. They have a large surface area. They contain macrophages to devour any bacteria. Remember our first line of defense, right? And there is two types of alveolar cells. So two types of alveolar cells, right? So we're gonna put A and B, okay? Actually, no. We're gonna put 1 and 2 because that's how they're called. So type 1 alveolar cells. These are the cells that they're part of a thin squamous layer that participate in gas exchange. So they are the one that divide the blood with the air and in the alveoli, so that carbon dioxide can diffuse out and oxygen from the atmosphere can diffuse in. And this is a very thin layer of squamous cells. And as a review of squamous cells, those were the cells that were very flat and very thin, like this, right? They need to be thin and small because if the cells are actually larger, like columnar or cuboidal cells, then gas exchange would not be as effective because the gases would have difficulty passing through these thickened layers of cells. So it must be thin, therefore it's a thin layer of squamous cells, right? The other type of alveolar cells, you have guessed it, they're called type 2. And type 2 cells, they have a function of production surfactant. So produce surfactant. Now, what is surfactant? Surfactant is a substance that's produced to decrease, the function is to decrease surface tension. Okay, and we'll talk about a little bit more a little bit later. So now we're going to talk about the dual supply circulation of the lungs. Yes, the lungs, as you have reviewed your anatomy, you know when the blood returns from the body via the superior and the inferior vena cava, goes into the right atrium, down to the right ventricle, and then bam, it gets pushed out through the pulmonary artery and into the lungs, right? Once it circulates through the lungs, gets oxygenated, gas exchange happens, returns through the pulmonary veins, through the left atrium, down to the left ventricle, and out through the aorta and to the whole body, and the cycle starts all over again. So that part of the circulation is the pulmonary circulation, right? Pulmonary circulation, and that's the one that I just talked about with the regular circulation of the blood in the heart and the lungs and the whole body. The other type of circulation is called the bronchial circulation. Now, bronchial circulation and pulmonary circulation, those are the dual supplied circulation in lungs. Let's talk about the bronchial circulation. So bronchial circulation is it branches off the thoracic aorta, and so it's a branch of the aorta, and the main function is to supply oxygen to the lung tissues itself, right? So supply O2 to lung tissues themselves. Okay, and these ones, they do not participate in gas exchange. So no gas exchange from the bronchial circulation. The pulmonary circulation obviously arises from the pulmonary artery, right? Because that's where the blood goes into the lungs. And they participate in gas exchange, right? So this is the whole normal circulation from the blood and the lungs, like we talked about. So participate in gas exchange. Okay. So next we're going to talk about the physiology of respiration. And the physiology of respiration involves three processes. So I'm just going to put here three processes. The first one is called ventilation. The second one is gas exchange. And third but not least, the last but not least, is transport. Okay, so if you start thinking about it, this would make sense. Ventilation is the movement of air in and out of the lungs, right? Like we talked about earlier, from high pressure, excuse me, from high pressure to low pressure. Once the air gets into the lungs, gas exchange must happen. Carbon dioxide must diffuse out into the atmosphere. Oxygen must diffuse into the blood to keep the blood well oxygenated and oxygen rich, so that the whole body has oxygen-rich blood to use, right? And then once that happens, it needs to be distributed. So transport, that's where it comes in. So ventilation, like we said, it's a movement of air, right? We're gonna put here movement of air in and out. Okay, and it's from high pressure to low pressure. Right? So gas exchange, this is just a diffusion of O2 and CO2, right? And gas exchange, there's three factors that affects gas exchange. Again, there's pressure differences, there's surface area, and there's the size of the molecules. Now, what does this mean? Pressure differences, it also plays a crucial role in gas exchange, and I want you to think about it. Once the blood goes from your right ventricle, which is oxygen poor blood, goes into the lungs for it to be oxygenated, carbon dioxide concentration in that part of the circulation is higher, right? Therefore, it's higher than the atmosphere, and CO2 will diffuse out because it's higher in the blood, lower in the atmosphere. And think about the same thing as in oxygen. Oxygen in the atmosphere will be higher compared to oxygen poor blood from that part of the circulation. Therefore, oxygen will diffuse in, right? So that's where the pressure gradient comes into play. High pressure always moves to low pressure, okay? Surface area plays a crucial role because we have to have a lot of alveoli in order to be able to perform this very thin gas exchange function. Because remember, the alveoli are so tiny, and their surface area, they're composed of those very thin squamous cells that we need a lot of them in order to be able to supply us with the proper oxygenation and ventilation in order to survive, right? So surface area is very important. And obviously the size of the molecule, right? So smaller molecules, they diffuse across the membranes easier, and larger molecules diffuse across the membrane with a little bit more difficulty compared to smaller molecules. And transport, once the blood has gone through the lungs to be oxygenated, returns to the heart again, and gets redistributed throughout the whole body. Now we're going to talk about lung compliance. So compliance just is a principle that talks about how well the lung expands, okay? So if your lung has good compliance, then it will expand and recoil with no problem. If the lung compliance is decreased, then you will have difficulty expanding, and the recoil of your lung will not be as effective. So increased compliance equals more air moves in, more air in, which equals more gas exchange, right? And the opposite is true. Decreased compliance equals less air in, which equals less gas exchange. Now, compliance of the lungs does play a role with surfactant. Remember earlier what I mentioned, surfactant that is produced by the type 2 alveolar cells. Surfactant, and we said that the job of surfactant is to decrease surface tension, right? So I want you to think about this. When the lungs are trying to expand, there's always a little bit of water molecules coating the outside of the lungs, okay? Water molecules, they have a tendency of trying to bind to each other. So let's draw a few water molecules here, okay? So H2O, so 2H and 1O. One water molecule, and here's another water molecule, and here's another water molecule, okay? Let's see. Now, water has a tendency of binding to each other via the very weak hydrogen bonds that hydrogen can exhibit towards the oxygen, right? Okay, let's draw another one here just for the sake of it. So as you can see, when the hydrogen weak bonds start to culminate and start to every water molecule starts to attract to each other, you can see that these two are going to try to come close to each other, right? And same for this one, and same for this one, and same for this one. Now, when we're trying to expand our lungs, that would not be good, because you have so much water that's trying to attract to each other that you will have difficulty expanding your lungs. So the lungs will not be able to expand because of this. Surfactant, what it does is, surfactant comes in and it breaks this weak hydrogen bond, okay? Like this. Once it breaks the hydrogen bond, then there wouldn't be as much force between the water molecules to want to attract to each other. Therefore, lung expansion is easier because you don't have that surface tension, okay? Next, we're going to talk about lung resistance. So resistance is the pressure inside the conducting airways. that must be overcome in order for air to be able to move in and out of the lungs. Okay, so pressure inside conducting airways, and it must be overcome in order for lung to be able to come in and out of the lungs. So there is a inverse relationship from resistance and airway diameter. So what it is the wide airways will lead to low resistance. It would make sense, right? Narrow airways will lead to high resistance. Okay? And this would make sense because the same thing with blood pressure. When in blood pressure, when your arteries are constricted, you will have higher resistance, right? Higher blood pressure. There will be higher pressure for the heart to overcome in order to push the blood around. Same idea with the lung resistance. If your airways are wider, then there's lower resistance. If the airways are more narrow, then you do have more resistance, right? So one equation that is used is 1 divided by the radius of the diameter to the power of 4, right? So what this means is airway resistance is very much dependent on the diameter of your radius or inside your respiratory airways, right? And like I was saying, wider equals low resistance, narrow equals high resistance. Now we're going to talk about some lung volumes and some capacities. This picture, I'm sure you have seen it in nursing school before, you might have forgotten or not. So this will be just a quick review, okay? So tidal volume right here in the yellow area, 500. This is normal breathing, in and out, right? Inspiration, expiration, normal breathing. It seems to be about 500 cc's. Now, once you take a nice deep breath in, this part over here, this is the forced air inspiration, right? So when you take a nice deep breath in, that will be the extra air that the lungs are able to hold, right? So we're gonna put deep breath. Okay, the expiratory reserve volume, the blue one over here, is after we go through a normal breathing cycle, after expiration. So when we inhale and we exhale, we can force some air out after expiration, and this is what it is. Okay, so it's forced expiration. So once we inhale and exhale, and after we have exhaled, we force air out, and we can still do that. Okay, obviously that will drain a lot of the air from our lungs. Last but not least, the green part is a residual volume. It's the volume that we cannot blow out. Okay, cannot blow out. And this volume here works to keep the lungs inflated so that the next breath that we take requires less oxygen, right? A good analogy to think about it, it's a balloon. Once the balloon completely deflates, it takes that much more force to reinflate the balloons, right? However, if the balloon is partially deflated, the next inflation of the balloon will be less work. Same principle in here, right? Now we'd like to review a little bit of ventilation and perfusion. This is termed as VQ, V for ventilation, Q for perfusion. During normal healthy lung, obviously ventilation and perfusion will match each other. However, when there's mismatches, there's problems, right? So sorry, I can't even spell mismatch. Mismatch equals problem. Okay, and we have three possible scenarios that this can go. We have low ventilation compared to perfusion, we have high ventilation compared to perfusion, and we have low ventilation compared to low perfusion. Okay, now we're gonna explore that a little bit further. So low ventilation compared to perfusion, low ventilation to perfusion, this would be called a low VQ, right? Low ventilation compared to perfusion, low VQ. This is where blood flow is normal or unhindered. However, ventilation is hindered. Okay, so low ventilation, air is so low air and normal flow, right? This is also called shunting. Next, we have, we have high ventilation compared to perfusion. This would be a high VQ, you guessed it, right? High ventilation compared to perfusion. This one is also called dead space. And air is, there's high ventilation, there's a lot increased air, but there is decreased perfusion, right? So one scenario that you can think about for high VQ is, for example, pulmonary embolism, right? Air you can still breathe in with no problem. However, the pulmonary embolism, because it's in the blood and it travels to the lung, it occludes some of the perfusion into the lung, so you have a high VQ state. For low VQ, there's asthma, there's pneumonia, right, where anything that would affect ventilation itself, but the blood flow would remain normal. And last but not least, we have low ventilation compared to low perfusion, right? And this one here is a low V and low Q, also called a silent unit, right? And this is bad in both scenarios, right? Where patients have decreased ventilation and the perfusion also is affected, for example, such as cases as in ARDS, right? Acute respiratory distress syndrome. And here's just some visualization. Low VQ, you can see over here, low ventilation to the lungs, but flow of the blood remains quite normal, right? High VQ is air comes in with no problem, but you have a blockage here, so blood flow is affected. And silent unit, when you have a blockage here and you have a blockage here, so you have ventilation and perfusion that are both affected. Next, I want to talk about CO2 and O2 in the blood. So oxygen, it's dissolved in the blood as well as carbon dioxide, but O2, about 3% of O2 is free oxygen, right? That is dissolved in the plasma, and the other 97% of it is bound to hemoglobin. And CO2 has a similar story. So 10% of the CO2 is dissolved in plasma, about 30% is bound to hemoglobin, and the other 60% is dissolved in the blood as bicarb. And that will lead us to the oxygen dissociation curve. This curve here, I'm sure a lot of you have seen it in nursing school, but might or might not have remembered it. So the oxygen dissociation curve, it's I like to call it a game of affinity. Okay, affinity is just how much attraction is there from the hemoglobin to the oxygen. Okay, so it comes down to chemistry, right? More affinity, that means that the hemoglobin molecule has a lot of attraction towards the oxygen molecule, and lower affinity just means the opposite. The hemoglobin molecule has lower attraction towards the oxygen molecule. Now, what's the significance of this? As you can see, the red one is a normal dissociation curve, okay, and we have the blue line and we have the green line. The green line, as you can see, has shifted to the right, right? So right, shift, and we're going to put here the green line, okay? And the blue, as you can see, has shifted towards the left, okay? So L for left, shift, and this is blue, okay? So now, what's the significance? When the oxygen dissociation curve shifts towards the right, right? That means that given a same pressure down here, okay, partial pressure of oxygen, given the same pressure, let's take 80 for example. Given a pressure of 80, it will lead us to a lower O2 sat compared to the blue, which also in the 80 we have a higher O2 sat. Now, what does that mean? Okay, so it means that when the oxygen dissociation curve shifts to the right, right, it means that hemoglobin has lower affinity for O2. Okay, and what this means is that the the hemoglobin molecule is willing to give out the O2 in order for cells to use, and that's what we want, right? Because oxygen, that is, it's bound to hemoglobin for transport around the blood, around the body. However, the cells themselves, they cannot use the oxygen that is bound to the hemoglobin molecule themselves. The hemoglobin molecule has to unload them, has to give that oxygen out to the cells, and that's when the cells are able to use it. So this part here, when it shifts to the right, that's what tells the hemoglobin has a lower affinity, so willing to give up O2 easier, okay? So it's willing to give up O2 easier. And when do we see this? We can see this, for example, when in fever, acidosis, exercise. So anything that will require the body more oxygen, right? Now, a left shift of the oxygen dissociation curve would mean the opposite. It means that hemoglobin has a high affinity for O2. Okay, so what's high affinity means? Again, it means that the hemoglobin molecule is unwilling to give up O2 easily, right? So right shift is willing to give up O2 easier, and left shift is unwilling to give up O2 easier. So what that means, it means that the hemoglobin molecule wants to keep the oxygen molecule attached to itself and not give it to the cells. Now, is this a good thing? It's not, right? Because that means that your cell will not be able to use the oxygen that is in the blood because the hemoglobin keeps retaining it and not giving it up. We can see this in, for example, hypothermia, right? Alkalosis, because the opposite of acidosis, right? Alkalosis, and carbon monoxide poisoning. So that's what happens. Carbon monoxide increases the affinity of hemoglobin for oxygen, and therefore it does not it does not release it easily. For that reason, people who are on carbon monoxide poisoning, they have normal O2 sats because their oxygen is saturated. It's just that it's not releasing the oxygen for the cells. Therefore, your cells starve to death, and people die from that. Last, we're going to talk about regulation of breathing. Regulation of breathing is done by 3 factors. Okay, so one is done by or at least control pardon me, controlled by the pons and medulla. It's controlled by the central and peripheral chemoreceptors. And last but not least, by stretch receptors in the lung. So receptors in lung. Okay. So the pons and medulla, they control the rate, the depth of each breath, the pattern, regular, irregular pattern, right? Excuse me. And inspiration and expiration. Okay, so the central and peripheral chemoreceptors. The central chemoreceptors are found in the central nervous system. They sense an increase in CO2. When there's an increase in CO2, it will talk to the pons and medulla, right, to increase the rate, increase the depth, so that we can blow out the CO2. The peripheral chemoreceptors are found mostly in the circulatory system, okay, and they sense a decrease in O2. So central increase in CO2 and peripheral sense a decrease in O2. So when they sense a decrease in O2, same. They send a signal to the pons and medulla to increase the rate, the depth, to correct that. And last but not least, the receptors in the lungs. They react to stretch, and it's more like a feedback mechanism, right? So when you're breathing properly and there's a certain amount of stretch, then that feedback system is sent back to the brain, and the brain says, okay, that's normal. However, if people are not breathing properly due to pneumonia, asthma, whatever, then the lungs are not expanding as properly, so there isn't that much stretch. Once the brain starts to figure out that, oh, there is less stretch, then it will trigger again, the pons and medulla to increase the rate, the depth, the pattern, and affect inspiration and expiration. Inspiration and expiration accordingly, to try to compensate for that, for that problem. Okay. And I believe that's it for this video. I hope you found it useful, and it was meant for nursing students as a review or anatomy and physiology of the respiratory system. If you like it, like and subscribe please, and I'll see you next time in our next video. Bye for now.